This is waking me up. And you're not even getting through a full sleep cycle, which is about 90 minutes, right? It's really, really hard to get momentum on that healing process.
That's why we wanted to make an episode on this, is when you understand what that is, because when you have an injury to a particular area, you're going to be more prone in the future to re-aggravating it.
Yeah.
That's okay. It's just understanding what you can do to reduce the risk and increase your resiliency.
All right, JT, welcome back, dude.
We're back, man.
We are back. Yes. I think we officially decided on a name.
We have.
After last episode to this one. Yeah. Do you want to share with everybody what it is?
Yeah, we went through a couple, had some help from different sources, but we landed on Joint Effort.
That's right.
As the name of the podcast. We're very excited about it. Again, this is first season. We're going to see if we like it.
Yeah.
As it rolls off the tongue, but that's at least the first edition.
Yeah, man, I'm super excited. It'll be pretty good. I think it'll really encompass just, again, our goal to come together as two professionals who have similar yet different careers, right? Coming together. And sometimes people think that chiropractors and physical therapists are kind of at war with one another, which they honestly have been historically, right? So this is a chance for us to jointly come together and also talk about joints.
Yeah.
Amongst other things.
A lot of other things in the body to talk about, but that's a big one.
There are a lot of them. I should know how many.
I don't know.
There are.
Actually, that's a good question.
Yeah.
I know there are over 600 muscles. I know that, but I don't know the joints. That would be.
Yeah, we'll make that. Yeah, it feels like something we should know. Make that part of our homework for next time. Yeah, we'll come to you with that fact next episode. Man, okay. So last time we really started an awesome conversation around pain, giving some context for what pain is, what it isn't, and diving into this topic that a lot of people want to know more about, which is what's happening in my body when I'm experiencing pain, right? And is this an indication that there is damage going on here underneath the surface? Is it something else entirely? What's happening? And we were able to get into that a little bit. And we're going to continue that conversation today to have a more in-depth understanding and explanation in terms of what pain is and in different situations, what might be going on there. I guess as a little bit of an overview, can you maybe do us a favor and just share a little bit of some of the highlights from the last episode in terms of some of the things that we talked about with pain and what's going on there with it, and what are maybe some important things? If somebody didn't watch last episode, definitely do that because this is going to build on that. But just quickly, maybe some highlights there to talk about.
Yeah. So the big overarching message is that pain is extremely complex. It's very individual to each person. But at the end of the day, it's something that is purposeful for your body. It's telling you something. It's telling you that there is an injury or damage to a particular area. If we're talking about an acute pain, and it's telling you to protect that area so that it can heal. So understanding that it's meant to be protective in a way, as much as it doesn't feel like it's protecting you, it actually is in the beginning. However, it can turn into what's called a chronic pain, which we'll be getting into today. There's a very, very important difference between those two things. And chronic pain is when things go beyond the biological, I'll say. It goes beyond just, there's tissue damage in my left hip, and that's why I feel pain there. That's when we talk about the more of the psychological, the social factors of pain, the influence of the brain on the pain, the nervous system. If you've built this expectation that pain is going to be there over time, that you're just going to feel pain more often in that area. Even if that tissue has had time to heal, you still might be feeling pain. And we'll get into that today about what the differences are there and how to treat those slightly differently.
Yeah, no, I'm glad you brought that up because when we talk about pain, some people might in their head go toward this low back pain that they've been dealing with for a very long time, right? Other people might be, reminded of a time that they sprained their ankle, and that first night when you go to bed after an ankle sprain, how painful that experience is. in my experience, it's always, the sprain hurts a little bit when it first happened, but that night when you're going to bed is when it really ramps up, right? So there's different things there. One is something that happened instantaneously, and now we have pain as a result. And then another one is something that's maybe a little bit more insidious in onset, right? So it's kind of just gradually crept up. And now you turn around and all of a sudden you're like, oh my God, my back's been hurting for as long as I can remember now, right? And so those are different things. Those are different situations. And so we're going to talk about some strategies with each of those. And I want to be really clear when we are talking through these to differentiate between when we're talking about an acute injury, something that has an acute onset. There's one moment that it happens, right? It flares up. Now I'm in pain, versus something that is more chronic, that is more insidious in nature, right? Those the rules and how we approach those things are different, right? And so I think to dive into that a little bit more, you talked about the idea that pain is an alarm signal, right? Pain is a signal that our brain is telling us, hey, pay attention to this. Sometimes it means that there is actual tissue damage going on, right? That there isn't a physical injury happening there. Sometimes it means that that's not the case. Sometimes it means that there is just maybe an activity or a movement or a position that we weren't really ready for, didn't cause any damage, but still caused a whole lot of pain, right? And so when we think about the first one, that's what we talk about when we think about acute pain, right? Those acute injuries. So let's dive into that a little bit and start with that. And then we'll maybe expound upon that a little bit more, go into some of the chronic pain, differentiate for folks what one means versus the other. And then we'll just kind of let the conversation go from there. So when we think about acute pain, tell me about like a few examples that you've seen recently maybe in the clinic of some acute pain, episodes that might give some more context for those who are watching.
Yeah. One example would be something that happened last week. I had a patient that's been healing from an injury to his thoracic spine, and he was doing a very intense upper body exercise, one that he hasn't done in 2 or 3 weeks. And after that exercise session, he felt okay during it. That night is when he started to feel some very intense re-aggravation of that pain. And he texted me the next day with a lot of worry that he had re-injured it, that he didn't know what was going on. And so that would be an example of something that his body wasn't quite ready to go back to that level of exercise. He was doing well, but it was still not ready for that intense of a session. So it just kind of overworked that area that was still building strength, still building resiliency. So he just went a bit beyond its capacity. And so we just went through a protocol to calm that system down for a few days. And as it's calming down, we're able to see what his new capacity is for getting him back to that movement. Calming him down a little bit too is the big thing. I think it was more mental than physical. Just helping him understand that he didn't do anything that was going to create this massive injury, that now he's all the way back to square one. He's fractured his spine. You got to make sure, because when you don't understand pain, you get this anxiety around it when you have it, especially if it's one that you've dealt with in the past. And that's our biggest thing. That's why we wanted to make an episode on this, is when you understand what that is and you can take some control over it, it decreases your anxiety around that initial shock of it, which can help in those initial days. Obviously, there's a lot more work to do after that, but that's one small example of a re-aggravation that happens to so many people. Happens to me, because when you have an injury to a particular area, you're going to be more prone in the future to re-aggravating it.
Yeah.
That's okay. It's just understanding what you can do to reduce the risk and increase your resiliency to making sure that if you do re-aggravate it, it's not going to set you back too far, the stronger that you are going into that.
Right. And so if I can ask, how long had he been dealing with before the flare up, how long had he been going through that mid-back thoracic spine pain?
Yeah, so that's been something he's been having on and off for several months. And that's why he reached out to me.
Yeah.
He couldn't find a long-term solution. So, we've been working a lot on certain things to get him back to a good level. And I hadn't seen him in a few weeks. He was doing some things on his own. He felt really good. He just went into a workout that he felt prepared for. And it was a kind of a learning experience for both him and me to know to, be really, really strict in those first few months of rehab, to be very systematic with that approach to reloading, even if you're feeling really, really good and you're like, all right, I'm good. I'm going back to doing whatever. Like, all right, let's respect the injury. It's been here for a while.
Sure.
Let's ease into it a little bit. So we had that conversation. I taught him some things, and it was good for me to reflect on that too, as a PT who's trying to give as good of advice as possible.
For sure.
Yeah, it's been on and off for a while.
Yeah. So that's a really good example also of kind of this middle ground, which is an acute on chronic, right?
Yeah.
So he's chronically been dealing with this pain that has kind of been ebbing and flowing. And now we had an acute flare up or an acute exacerbation of something that was a chronic condition, right? So we classify that as acute on chronic. So it's a little bit of has some acute components to it, but then also there's this kind of chronic underlying condition there as well, which I think as we dive into this even more, we'll start to hear in that story, I think some of the elements of an acute injury versus chronic pain and how his story kind of plays into those as well.
Yeah, you're seeing how complex this is.
It
it's
is.
Acute, a chronic, acute on chronic. I don't think there's chronic on acute. I don't think it goes the other way. Subacute. There's so many different words to it, but this kind of helps explain. These are two doctors that are talking about it, and we're still learning about it. So it's understanding that it's something that it's a lifelong process of understanding this.
Absolutely.
Stuff,
Yeah, I think through a few of the ones that I had this week, two really come to mind in terms of acute injuries that came in. One was a CrossFitter who sprained his ankle. So he had an ATFL sprain, probably grade 1, maybe grade 2, but he was walking around on it, just fine, but it was pretty swollen up, right? And he was coming down off of a box holding two 50-pound dumbbells, landed on his foot wrong and rolled. Already kind of a bigger dude to begin with, like tall, very muscular, and he's also holding 100 pounds of weight. And so he lands on the outside of his foot, rolls to the outside of his foot, and pop goes the ankle, right? You get that acute episode of injury and pain. And he came in with some bruising, some swelling, pretty classic acute ATFL or lateral ankle sprain, right? And so we're working through some of those early phases, the first few days, coaching him, guiding him through, hey, here's how you need to approach this and handle this in the first 72 hours, which we're going to get to. And then here's what to expect over the next 3 weeks. And then here's what to expect beyond that, right? And so kind of going through all of those different phases. Very similarly to that, had another guy come in who had a hamstring strain playing pickleball. The pickleball injuries are real, man.
It's a good niche to get
It is a
into
niche.
right now.
It is a niche. Absolutely. So, he was playing doubles. I've never played pickleball. Have you
I've
played?
played it a couple times, doubles. Yeah. And I'm as bad as I would want to be at something. I'm not going back.
Yeah.
Dude, at this point, easy. It's not.
I don't think it's easy at all. At this point, also for me, it's so trendy right now that I've got this little bit of social rebellion that's in me that I'm like, dude, I don't think I'm ever going to
Fair
play.
enough.
It's like, everyone's doing it right now. I think I'm just going to go the other direction. It's like, it's like the Taylor Swift of sports. I don't know. But as fun as it might be, but the other thing about that is that, so with doubles, apparently it's much more fast paced, right? It's a much more fast paced game. But you're dinking and doinking back and forth, way quicker than you would in singles. And so lots of quick changing direction. He stepped, overextended his foot a little bit and just got a nice old pop through the hamstring, lots of bruising, et cetera, et cetera. And so, same kind of situation, like that's an acute injury, right? An acute onset of something. So, JT, as a physical therapist, someone comes in, let's say that in this situation, if they are fortunate enough to be able to get with you an appointment the same day, which I know is not always possible. You've got a very full, busy schedule. Someone can get in with you same day. Hey, JT, I just did this. I just got this injury. What's first line of defense here? What's your game plan? What's your attack? How do you approach this situation in the first few days?
Yeah. When I first talk to them, I want to understand exactly what happened. I need to know, was this an acute injury where you felt something pop? What happened? I want to know the moment that it started to hurt. Was this something that you were doing weightlifting, or did you just wake up with this new pain? Whatever. I want to kind of get a good understanding there. And then from there, I'm trying to get a sense of how intense their symptoms are. What's the severity of this injury, so I know where to start with them in terms of some sort of treatment. Am I just trying to calm the pain down? Am I trying to calm their nervous system down? Do I just need to talk with them for an hour? Sometimes talking with someone for an hour about their pain is more beneficial than just doing a bunch of treatments on them. They don't know what's going on. So I'm trying to figure out what's the best sort of treatment for them, and that's based on just talking with them, their severity of symptoms, doing some tests on them, seeing if there is like how bad the injury is. I need to see if this is something that I can treat, or if it's something that, if it's same day, do I need to refer them to go get some imaging? Do I need to have somebody else treat this if it is very, very severe? But in many cases, I'm trying to, at the very least, calm the system down. That's my number one thing. Like those first 3 days, like we're going to talk about more specifically here. After an acute inflammatory response like that, we know typically, it depends on the injury, usually around 72 hours at least, to have the body go through its natural healing process. So educating them on that, it's a lot of patient education on that first day, and then setting out kind of what you talked about with your guys, is setting an expectation for them when they, again, going back to understanding what is happening in your body right now, knowing that it's overall normal in most cases. And just kind of giving them an expectation that tends to really help. I can tell there's just like this ease that comes. They're still pissed that they're in pain. Like they're not like, oh yeah, this is great. All right, I love this. Like it still sucks. Right. Pain sucks, but like having an understanding kind of going forward. And then it's just making sure that I'm following up with them. When I have somebody come in day of their pain, like me personally, I like following up with them every day. Yeah. At least a text, like, hey man, how you doing? Right. Just to make sure that they know they're supported, they know what the plan is going forward.
Yeah, absolutely. I love that. I think same situation, more tactically, a few of the things that I typically try to look for is, okay, let's see if we can find positions or movements that are currently not provocative, right? Yes. Let's find things that, okay, if you're in a ton of pain right now, you just, flared up your low back, right? What can we do? What position can we put you in? What small, simple movements can we do that are going to, at best, make the pain feel better? That would be awesome if we can do that. And sometimes we can. Sometimes an inflammation's so high, the best thing that we can do is just find something that they can do that doesn't make pain worse. And now it's, okay, let's dose that over the course of the next couple days. We start getting the blood flow pumping. We start getting some of that inflammation flushed out, right? And we start reintroducing the body to some movement. And we quite literally can change the trajectory of their next 3 to 12 months if we can get some early movement, some interventions from a movement standpoint early on, right? If we can get them going in a direction where they immediately after their injury feel like, okay, wait, I can at least do this. Like I'm not all hope is lost, right? And then slowly over time, we start to build and grade that up and get them to a place where they're doing more meaningful activities. But in the here and now, those first few days, it's let's just find something that you can repeatedly do throughout the day. I think that helps physically and physiologically, like how I just described with with getting blood flow, with getting some motion through there, right? With just kind of flushing things out can be really, really helpful. But it also, I think, helps psychologically and mentally as well for somebody to have something else to focus and anchor on, something that is in their control. So oftentimes being in pain, it feels like it's very much out of your control, right? It's like, well, if I could do something to fix this, I wouldn't be here right now. So clearly, they're at this point where there's very little that they can do about it. And so it's like, okay, let's start with this small thing of here's what you can do right now. And now we can anchor and we can focus our attention and energy into saying like, yes, you're in pain. You're going to be in pain for a little bit, but for the next 72 hours, we're not necessarily concerned about this. I'm only concerned about you doing this one thing. And you do this one thing and repeat it for the next 72 hours. And then let's kind of like reassess where you're at. And I think that can be helpful sometimes too, to just say like, all right, my focus right now is in just doing this movement or being in this position or whatever it might be, to at least start to kind of regain some control here. Right. And so that's typically what I think about. A lot of people will ask the question in those time periods, though. I'm sure you get this question a lot. They'll ask the question, is heat or ice better? Should I heat or should I ice? And I think what they're really looking for is, what is a way that I can speed this thing up as quickly as possible? Like, I don't think people are married to the heat or ice situation. I think they're just looking for like, what else can I do? Because I'm really miserable right now. And so there are times where I'm like, hey, I don't want you to do either of those things. And there are times where I will say one versus the other, but I'm curious as to your contextually in your clinic, like when do you recommend heat versus ice? Maybe you can kind of explain a little bit of the old school methodology behind RICE, right? Yeah. Rest, ice, compression, elevation. Those four things have been taught in sports medicine for so long. Curious as to your opinions on that, when you use that, when you don't. What's your general, philosophy and approach to the heat versus ice situation?
Yeah. With ice and heat, I don't use it so much in my clinic. I don't even have those things in my clinic. And if somebody asks me about it, typically my general response is to educate them a little bit on the old ways of doing the RICE method, because that's everyone's first thought is ice and injury. And it's been shown with recent research that it actually delays the healing process because it's an anti-inflammatory, and that your body needs that inflammation in that process. So it's stunting that, even though it feels good for 15 or 20 minutes, whenever you take it off, the pain's going to come back, and now that maybe that inflammation has been stunted. So try to educate them on that. And usually after those first 3 or 4 days, when technically we're thinking that the inflammatory process has calmed down and it's still painful, that's when I'll say, icing, a couple times a day as necessary is okay, just to calm the system down. If it gives you 15 to 20 minutes of pain-free life and you can go do some movement, or you can, do something that's less painful and just can give you a mental break, absolutely go for it. It's just in those 3 days, just really respecting the tissue healing is what we're trying to do. And if in those days, that's when I'm, as opposed to ice or heat, I'm thinking more like the NSAIDs or muscle relaxers that a lot of times are demonized in the health and wellness. Never take pills, never do any of that. And usually, yes, we don't want you taking those things and relying on them. I'm all about the mindset with that. If you go into it knowing that, okay, these next 3 days are going to suck, I have to go do this presentation at work or I'm going to get fired, I have to go do this, like, okay, take it. It's okay. It's not going to kill you. It's just something to get you through that presentation or whatever you have to do. It's just the mindset going in, knowing that this is going to mask the pain. And so when it's out of my system, the pain will come back. And I need to make sure that while I'm not in pain, that I'm not doing something that's going to injure this more. So don't go out and do a crazy CrossFit workout after the day after you did something. And I'm big on it with sleep too. I think we're going to talk about this too, how important sleep is to the healing process. And if taking a muscle relaxer or some sort of a pill that helps with pain relief, if that helps you get better sleep, go for it. That's my opinion. So yeah, that's kind of where my head falls with most of that stuff.
Absolutely.
Yeah. What about you?
Yeah, I don't think there's anybody who doesn't get better sleep on Flexeril. Like, holy cow! Dude. Like when I herniated a disc in my back, I got some muscle relaxers, Flexeril, and dude, that stuff knocks you out. Like man, that's a great sleep. That's a great sleep right there. But absolutely, right? Like my general rule of thumb is if your pain's waking you up more frequently than every 2 hours, inflammation levels are so high right now that it's almost like it's really hard to gain traction. So if you're at the point where you can string together, 2 to 4 hours of sleep in a row, and it's like, then you're getting up and you're moving around, my bias typically is like, hey, if you can stand it, let's try to stay off of it just to allow the body to stay, keep its natural healing course. But again, like if you're at the point where it's like, hey, this is waking me up, and you're not even getting through a full sleep cycle, which is about 90 minutes, right? It's really, really hard to get momentum on that healing process. Like the hormones and just the processing of everything that your body goes through during a sleep cycle is constantly interrupted. And so that's definitely one of those things where as a general rule that I like to say, hey, how many hours would you say you're sleeping uninterrupted? And if they answer less than 2, it's like, okay, yeah, let's go down this path of trying to get a little bit of extra help with that. But if they're stringing it together and they feel good about it, then I'm saying, it's more up to you, and the prescribing doctor, whoever's given them that, if they want it or not, that kind of decision between them. But as far as what I see on the rehab side, I'm like, okay, this isn't going to impede our progress or necessarily help it if you're at least getting, that 2 to 4 hours uninterrupted. I think too, I like hearing your philosophy on the kind of ice rice kind of situation where you like to wait for those first 72 hours to clear and then kind of give them the green light to start using it as they need. I really like that. I haven't really thought about that as much in terms of like the timeline with it. My general thing is like, okay, if the ice is going to help you get to the point where you can do some kind of repetitive movement, that is going to help you, right? It's just going to kind of, block out some of those pain receptors for a little bit. I think about like, we'll go back to an ankle sprain, for example, right? And icing an ankle sprain. It's like, do you ice it or do you not ice it? And certain people in our professions are very anti-ice right now. And then there are other people who have like never learned anything beyond the 1980s, 1990s rice, right? And so that's just all they know. To me, it's like, okay, if we can use that ice to help calm things down enough to where you can start doing some ankle mobility work and some dorsiflexion and some, kind of controlled rotations with the ankle. And that can help us do that temporarily. We know that movement, that motion is going to help them long-term. But sometimes things are so guarded and painful that they won't really get the benefit from those that they would otherwise get right now. So there are some times where I'll say like, hey, go ahead and ice and then let's hit some of these to just, calm things down a little bit and allow you a little bit more range to be able to get through some of those movements, right? The other thing I feel like I use ice for, and heat as well, I think goes into this bucket. But like if you think about low back pain, for example, ice or heat. And the old way of saying it was that the first 48 hours, ice, right? After 48 hours, you switch to heat. And to me, it's like, dude, do whatever feels good to you. Yep. Like if it feels good, then it doesn't really matter one way or the other. To me, it's okay. If they're really acute, what's actually going to be the win for the ice? The win is going to be, they're probably going to get into a position that's not provocative for them. And they can just like sit there and hang out, and almost like gives people something to do. To pass the time while they're like in those pain-free positions, right? And that's really important in acute low back injuries, is finding positions of relief, finding things where it's like, hey, stuff can settle down, and you can kind of like just like let your nervous system calm down a little bit, get out of that fight or flight for just a few minutes at a time to kind of reset things. And then oftentimes people can get out of those positions and they start to feel a little bit better as well, right? So I think there's a couple different ways that you can use it. I think relying fully on ice for some kind of like healing benefits, or heat for some kind of healing benefits, is not the direction to go, right? Use it as a tool, but also kind of understand why you're doing it. Same thing with the ibuprofen, right? Like NSAIDs, ibuprofen, muscle relaxers, steroid packs, like all that stuff, I am all here for, as long as we're doing it in the context of understanding what our trade-offs are and understanding what the long-term goal behind using it actually is, right?
Absolutely. I think that's what it comes down to, is your mindset around it, knowing that this stupid analogy, and I thought about it and I don't even think it makes sense, but it's like you're using those tools like that, the ice, the heat, the NSAIDs, whatever. That's the gas in your car, right? When you're at the gas station, you're putting gas in your car, that's going to allow you to go further. You don't put the gas in your car and stay there at the gas station unless it's a really cool gas station or there's someone you're attracted to that you want to talk to. But other than that,
like
you're going, so you have a goal there, right? I'm trying to get to this next point. So get in your car, step on the gas and go. Don't just like keep filling up your tank with gas. Like that's not going to get you where you want to go. I don't know if that analogy works, but that's just kind of that's how I want you to think of those things. It's their tools to get you to another point. They are not the goal to keep using that. That's not going to, solve the issue, but it's just your mindset going into it. How are you using those things?
Absolutely. Yeah, I know. I love that. Let's talk a little bit about the acute injury, because I want to get into the chronic stuff too. Because quite frankly, I think most people listening to this, they may have experience with an acute injury at some point in time, but I would imagine that most people listening to this, just statistically, don't currently have an acute injury going on, right? Most people, if they are in pain, are probably in the chronic pain camp, right? Or something that is closer to chronic than it is to acute. But let's talk a little bit about the timeline process of acute injuries and what people can expect. Maybe some of the big milestones or just general frameworks. Again, it's going to be different from person to person and from tissue to tissue, right? So a back is going to heal differently than a shoulder, going to heal differently than a knee or whatever. But generally, tell us about some of these from a conservative care standpoint. What are some of the timelines and things to be aware of in the recovery process?
Yeah, so we talked a little bit about that 3-day period. So just that inflammation is going to really ramp up in those first 3 days. So it's just kind of that expectation that over the next 3 days, after something is ramped up, that your body's going to be going through this process where there's a lot of fluid building up, there's a lot of inflammation, a lot of sensitivity in that area. Your body's protecting it for those first few days, and you need to respect that. Find those movements that you can do, but really you're just respecting it, protecting it through those first 3 days. And then you get to that, from the 3-day to 21-day period, that's, because at 21 days is, when we start to consider it subacute. From that 3-day to 21-day period, that's when we want to start thinking about, okay, how can we, now that we know that the inflammation is technically down, how can we start to get you back to doing some of those movements that you want to get back to in a safe way, allowing this tissue to heal. So during that time, we are still respecting that there's an injury here, that even though the inflammation maybe has calmed down, the tissue, depending on what type of tissue, it could be we're talking about disc herniation, are we talking about a muscle pull, are we talking about ligament, all of those. There's so many different, I won't go through all of them, but knowing what you're dealing with, and there's a chart that you can look up online, tissue healing timeline, that breaks down each of those structures, how long for each of those structures, and you can, so to kind of wrap your head around how long this will take to heal. But within those 3 weeks, like that's when you want to start seeing, what can you do, continuing on that pathway of slowly progressing exercises to the point that you're feeling like you're making some momentum and getting back to what you want to do. Because those initial weeks are really important, like you mentioned, on the long-term aspect. There's been a lot of good research about early mobilization, early treatment for those for those injuries, and how they help you long-term. So during that time, you're really trying to focus in on that. And then that's after those 21 days, we get into some things about gradually exposing the body to different challenges, which we'll get to here in a second. But that's kind of what I'm thinking of, those first few weeks of an acute injury.
I love that. Maybe we can link to that chart in the show notes.
Yeah, I should have memorized it before. There are a lot of numbers on there. I'm not good at memorization anymore. I lost that skill.
Yeah, once you left school.
Yeah. Oh yeah, all that went out the drain, dude.
I don't even know if we have show notes, but if we do, we'll link to the chart.
We'll
link to the chart in the show notes.
We're learning how to podcast.
That's right, man. No, I think that's a really good framework to have, knowing that things will probably ramp up in the first 3 days. The natural course of inflammation takes about 21 days to kind of cycle through, right? Mm-hmm. So at the end of that 21-day mark, we'll kind of be on the up and up, right? And we should expect potentially smoother seas, from that point forward, where we start to re-expose people to, gradually more and more demanding things. We start to build up the capacity of that tissue to tolerate its normal function again, right? Yes. And that's the general trajectory. I think that's good to highlight on. And then I think the important thing also is someone recognizing and asking the question of, well, when do I know if I am good to go again? This like good to go kind of phrase that, quite frankly, I don't ever use. I try not to use good to go, right? Not because I don't believe in it, but I think it gets thrown around too much. I hear a lot of other providers, particularly like, orthos and things like that. Again, that's not intentionally like, shaming a different profession or whatever, but just what I'm saying is like, yeah, I got cleared and they said I was good to go. And then we go and we actually test them and we test their capacity and realize like, dude, you are not good to go. Like you are a time bomb for this thing flaring up again. And so I'm curious as to like how you handle that situation. The way that I like to do it is through data and through numbers. So very specific testing criteria to make sure that, hey, if you're not hitting the markers of what is standard for you as an individual, depending on your activity levels or your age demographic or whatever, and you're still failing those tests, you might be pain-free, but that does not mean that you are good to go, right? Like we actually have to remember that rehab doesn't stop when pain is over. We keep going back to ankle sprains, but grade 1 ankle sprains are one of the most, I would say they're one of the most like sinister musculoskeletal conditions because they heal and recover on their own pretty quickly. But what's left in the wake of them is typically a lot of functional issues, balance problems, strength and coordination deficits, right? And so then you see somebody who, you'll do like a drawer test on their ankle, or you'll test, for those who don't know, drawer test is just a measurement of like ankle instability. And you'll see that like, oh my gosh, like this person has some crazy laxity and instability in this ankle. And you'll ask them like, well, have you sprained this before? Like how many times have you sprained this? And they're like, oh, I lost count. Like it's probably been over a dozen. And it's like, what? They're like, yeah. It's like, I just keep doing it. At this point, it doesn't hurt anymore. I just roll it and sprain it and I move on my way. And it's like, oh yeah, that's because you have no more ligament left. Like it's gone. So to keep people from getting to that position, we typically like to make sure that they're testing out their dismissal criteria, that they're functionally operating at the level that they want to be, which typically happens long after pain subsides, right? It takes a little bit of time to get back up to that point.
Yeah, no, absolutely. No, it's a good marker to have that in everybody's rehab protocol. If you look online, ankle sprain rehab protocol, most likely you're going to see 4 phases of a rehab protocol, and each you have to earn the right to go to the next phase. I'm big on that. You have to earn the right to go run. You have to earn the right to go Bulgarian squat. Like all of those, like name an exercise. Like if that's something that they currently cannot do and they want to know when they're good to go, I'm going to lay out, okay, here's test X, Y, and Z that I need you to pass so I know that your tissues are strong enough to uphold this exercise, being able to not only do it well when you're performing it and feel good, but not have a re-aggravation the next day. Kind of like my patient case the other day. I think that's a good example. I see that so often, and it is frustrating, really. And I have a personal story on that. Is when I was going through my rehab for my shoulder back in high school, when I tore my labrum, had surgery, whatever. I went through a PT mill, didn't really have much guidance. I just did my 12 weeks, got out of there. They were like, all right, you're good to go. They never once tested my overhead stability, never once tested my strength. At the end, I was a wrestler, so my shoulder needed to do some crazy stuff. But they were like, yeah, good to go. All right, great. Back to the mat. Second match back, I re-tear it. And so that has stuck with me, and that's been a driving force for me for my entire career. So yeah, before I let anybody go back to doing something that they're not able to do currently, that they want to get back to do, I have a conversation with them about the risk of re-injury, not fearing it, respecting it, and knowing that rehab is like you said, a lifelong thing. It's something that you're going to have to take care of, but that's going to allow you to do those things long term and not have a re-injury. So yeah, no, we're big on that in the rehab field. Absolutely.
Yeah, no, I think that's really
I'm
key.
glad you brought that up. That's important.
Really key. Yeah, and I think we're starting to get more literature on return to participation before return to play. And there's some guidelines in terms of, okay, if you get dismissed from therapy, what is your time where you're allowed to drill, you're allowed to practice, you're allowed to do that before actually going back into full live play? Because live play or match play or whatever it is for your sport, those demands they're way less predictable, and there quite literally is still an adaptation period that the body can only go through when it's doing the sport or it's doing the activity that you're trying to get back to. So like wrestling, for example, it's like how long of just wrestling practices did you do before you went back to your first match?
I mean, a week? I don't know. Like I literally was like, oh, I'm good to go. All right, back to the mat. And it was okay. I could feel like, okay, it's still like a little unstable, but I was a 16-year-old kid. I just wanted to wrestle. So I was back. I just thought, oh, doctor said I'm good. So this is how it's supposed to feel, I guess. And then, just second match. Never had any return to participation. None of that. None of that. So that's that'll stick with you.
Yeah, it sure will. Yeah. It sure will. So. Let's talk a little bit and pivot into the more chronic pain space. Yeah. We talked about this even more so last episode, but I want to kind of tease out the difference between what we just talked about being an acute injury, the acute phases of pain, and how chronic pain is different from that. So one of the things that you and I were talking about offline is this process that I've used for a very long time that was coined by one of my mentors, Jason Holm, which is we always called this like the pirate noise, like ARG, right? Because it is ARRG, which essentially stands for awareness, reset, regain control, and then graded exposure. And we'll kind of dive into those things. But in chronic pain, I think this becomes very, very important because unlike in acute pain, there's oftentimes not a specific mechanism that leads to the injury, right? It is often something that just, maybe it was there one time in the past, but at this point with chronic pain, someone has been dealing with pain for 3 months or longer, they're now officially categorized into having chronic pain if it's been longer than 3 months. And so what is different in your mind about how you approach somebody who's coming to you and they said, hey, I've had low back pain for the last 6 months, for example, versus someone who says, hey, I was bending over to tie my shoes yesterday and I heard my back go, right? How do you approach that differently? What's that look like for you? And what different considerations do you take with those?
Yeah, with chronic pain, I want to dive a little bit deeper into the history. I want to know, when was the first occurrence of this? If they've been dealing it, is it only 6 months, or did you deal with this also when you were in high school? Did you have an inciting injury that triggered this whole cascade that's been happening over the last few years? So I want to know that, because one of my favorite phrases is the mystery is in the history. So sometimes by just diving into their timeline, we can start to pick out points of these things that like started to make these triggers happen. So like I'd have pain for 6 months, I'd do something and then it would get better, and then 2 years would pass, I'd have it again. Like, what was that thing that would trigger it? I want to figure out what that trigger is. We're having a longer conversation about that, and anybody that's had chronic pain. And then from there, I want to start to kind of break down their belief system. I want to see, what kind of psychological, what kind of social factors could be at play here? Because I know if they're coming in with pain that's lasted more than 6 months, I'm most likely dealing with something that is not purely biological. There certainly could be some, and there might be, like, that's okay, but what are some other factors that might be playing into this? How has it affected their lifestyle? What things are they currently not doing? Because I want to get to know their psychology, the social factors around this, and educate them a little bit on that before I even dive into the objective, talking about the structures around it. And then I also want to know what they have tried to solve it. What have you been doing? Has it only been passive treatment, only the ice and heat without any exercise? Or has it been, they've tried certain things and it hasn't worked for them? I'm just trying to get as much information as possible. And then from there, I'm trying to see, what can you do? What's your entry point? That's a big word that I want everyone to take away from this, is what's your entry point? Because on that first evaluation with a chronic pain patient, similar to what you talked about with someone that's going through an acute injury, injury, what can you do currently? What position can you get in to do a certain movement that doesn't increase your pain, that you feel okay doing, that I know is going to get you closer to where you want to be, which is full function. And then start to educate them on how we can use this entry point and build off of it slowly but surely, understanding that it might be a slow process. If you've had pain for 6 months, it might take another 6 months to fully heal. But along this path, we're going to slowly inch up each week if we can, knowing that there will likely be some exacerbations along the way if there's been chronic pain, but understanding that just because you have an exacerbation, if you do, that does not mean that you've damaged yourself. Like, let me know about it. We can talk through it, make sure of that. But just educating them on the process of getting them back and letting them know that it will be a longer process, most likely. A lot of education, as you can, I'm big on that talk that first time I'm seeing a chronic patient. And then everyone's different, but that's kind of my mindset going in. So where do you land on that, a chronic versus an acute patient coming in?
Yeah, absolutely. I think to kind of go back to that ARRG situation, that framework that we were talking about, the first phase to me is awareness, right? Having the conversation, asking the questions that you just asked to try to piece together some of the things that they can do and can't do, right? So like, let's just see where we're at. We just have to figure out where are we right now, because if we can understand where we are currently, we know more easily where we want to get to. And now it's just a matter of bridging the gap between those two things, right? But if we don't fully understand where we are currently, it makes this really, really hard. And in particular, if the patient doesn't understand what are their triggers, they don't understand like what are the things where they can actually do them and feel really good. What are the things that they can't do that they would like to do, right? You know, we have to get a really good understanding of where somebody is right there first, because again, they're already coming in having a pretty good idea of where they'd like to get to. So what I view my job is at the first few weeks is getting a handle on where is somebody right now? And sometimes that takes a little bit of some trial and error. Sometimes that takes like, okay, I think they should be able to do this and feel good about it. And then it doesn't go well. It flares them up, right? And it's like, okay, well now that didn't work. So now we got to go back to the drawing board, right? And then sometimes you just hit the nail on the head from the get-go and you look like a hero and it's like, all right, sweet, this is awesome, right? So you always hope that that's the case, but sometimes it doesn't happen. And so once we have that awareness piece, now we can start to reset things, right? So now we start to get them into a place where, hey, if they're like we talked about, an acute on chronic, so they have a chronic condition, they have a chronic pain that's currently in a flare, we need to reset that to get it to a workable baseline where we can say, hey, we can work with this, okay? And that's kind of those first two, that awareness and that reset, they kind of happen pretty early on. The next big hurdle to get over is this regaining control. And this is really where we start to piece together and feeling like having somebody start to feel like they are now in the driver's seat of their pain. Their pain still might be in their car, like to go back to the car analogy. It might still be in the car, but at least they are driving the car instead of the pain driving the car. And once they're in the driver's seat, now we can start to make really, really good strides forward to the point where over time, they're starting to understand more and more of what they're able to do, what they're not. And we start to add, if you think about it as two different buckets, right now at the beginning, their bucket of things that they can't do is probably more full than their bucket of things that they can do. But over time, we start to pour a little bit of that one bucket into the other until now the things that they can do are outweighing the things that they can't. And the final piece is the graded exposure piece, which really is the putting on strength and resilience on top of that. And so that is where it gets to the point of, okay, now that you're at this point, we're going to start to turn up the temperature a little bit. And I want you to prove to me that this doesn't flare you up, right? And show me that it doesn't flare you up. And that's when we really get into, we touched on this briefly last time, but we get into that expectation violation where someone will have this activity. Maybe it's like getting down on the floor to play with their kids. Maybe it's deadlifting. Maybe it's going on a run, right, for the first time. whatever it might be that to them, they think in their mind, oh my gosh, as soon as I do this, my pain's going to flare up again. Because that is very much a internal battle of somebody with chronic pain, right? Is a little bit of that. There's a little fear that's there. And so we have to break down that fear through exposure and through showing them that, hey, they're going to go do this thing and then they're going to do just fine. Right. And we actually learn a lot about this process through some of the research in PTSD recovery, and exposure therapy is one of the big ways that individuals who are suffering from PTSD can start to regain some control over those triggers again. And it's being exposed to the same stimulus, but now getting a different outcome. And it's one of the big things that in the pain world, that once we start to piece together those expectation violations, oh my gosh, I'm going to do this. I'm going to pick this weight up and my back is going to go out and I'm going to be in pain for a week. And then they do it, and then they do it again, and then they do it again, and they do it again, and they don't have pain with it. And it's that moment in time that the story of chronic pain starts to unwind. Right? That is the moment where things are forever different from that individual, because they have, for the very first time, something that they expected to hurt and then it didn't. And so much of chronic pain becomes this mental and psychological and emotional battle with pain as well, that I think, we can counsel them and talk them through things all the time, and even educate them in terms of what pain is doing and what pain's not doing. But until someone experiences that and lives it out for real, it's just going to feel like we might be just shouting into a canyon, and just hearing our own voice come back, but it's never going to actually be something that they take to heart, And so to me, I like to focus on the action piece and focus on, all right, getting them, the whole process of chronic pain rehab is getting them to that point of that expectation violation. And once we do that, it's like, dude, now we can party, because now things are smooth sailing.
Yeah.
And that doesn't mean that it's going to always be like the smoothest sailing. Like, it's very common to still have flare-ups and things like that along the road, but the framework and the mindset around those things is very different now.
Yeah.
I've gotten to this place before, I can get there again. And so I think that's typically how I like to frame that. I think it's also important maybe to touch on a little bit. You used a really cool analogy that I want you to explain more about, how chronic pain is sometimes like walking through a field.
Yeah.
Can you say that again?
Yeah. So I love analogies to understand pain because of how complex it is. It's a very simple one, but thinking about how our brain has this expectation of pain in a certain area, no matter what we're doing. Think about a field of long unmown grass. Your dad would have a heart attack if he saw it. He'd want to go mow it right away, very long, but it's your pathway to school. Right. And every day you take the same pathway to school. You walk the same route. And over time, that long grass, it starts to muddle down and it starts to get lower and lower, and a path is created. So now there's long grass all around it, but then there's this path of broken down grass, whatever, because you've been stepping on it. So you're naturally going to want to take that path every single time. That's what you have learned. Think about that in terms of your brain having this, and your nervous system having this pathway to pain in some direction on your body. So if you've had, say low back pain, and every time you do a deadlift, or every time you bend over to pick something up, you get this pain, and that doesn't mean that there's damage there. It means that your body has created this pathway of pain that you can think about, like that pathway that you would take on a walk. It's just your body's learned that it's the easiest way to get there. I don't want to go through that other long grass. I'm going to go through here. That's what I've learned. So it's just another way of understanding that. I'm not saying the phrase that we create our own pain. That's not exactly what I'm trying to say. It's our experiences, our thought processes, the things that we've been told in the past, like those do matter when we think about why this chronic pain has happened, and why it's so easy for the brain to create it, and understanding that, yes, pain is created by the brain. That does not mean it's not real. Sometimes I hesitate to say that. I'm not saying that it's all in your head. I don't like that phrase because it is real pain, but it is a good understanding of knowing that the brain does create the pain. When you can understand that, that kind of takes the fear away from there being some damage to your body, and knowing that, okay, this might be a pathway that my brain has created over time.
No, I love that.
That.
That's so good, because ultimately, to kind of dive into that a little bit more, a little bit of neurology here, but we have these receptors in all of our tissues throughout all of our body called nociceptors, right? And nociceptors they're basically just messenger nerves, right? So they get some kind of information. They are excited by stimulus in some way, right? So it could be pressure, it can be it can be it can be something that's like sharper. It can sometimes be tissue damage, right? By the way, that when you are sitting here and having to readjust in your seat, okay, your nociceptors are the things that are telling your brain, hey, it's time to readjust. Yeah. So if you were to sit there for way too long and ignore them, like your butt would probably start to hurt. Okay, because you've been sitting for so long, if you're ignoring that nociception. But nociception in and of itself is just a signal going to the brain. And the brain can choose to basically do three things with that. It can ignore it. It can tell you to do some kind of action to move away from it, or it can perceive it as a threat and can perceive it as pain, right? And so that is essentially what's happening, is that your brain starts to accumulate. When I'm getting nociception from this tissue, I've been so accustomed to thinking that this is pain, that this is damage, that I'm going to continue to signal the body, hey, this is pain, this is pain, this is pain. You need to run away from this or shy away from it. But we have to remember that sometimes it's just nociception that is being perceived by the brain as a threat, when in reality it may not be, right? And in chronic pain, this becomes very true, because this pathway is, like you said, it's grooved over time, right? It's repetitive exposure to these things that the brain starts to learn and starts to try to get smarter about it, but it, in a weird way, is kind of doing the wrong thing. And it's interesting that it will do that with nociception, and we'll start to become accustomed to that signal and perceive something that's not there, which is very different from you walk into a room and someone just farted in the room, and your brain immediately and your nose is like, oh my gosh, like, holy cow. But then in a couple minutes, it's gone, right? But then somebody new walks in and they're like, oh my gosh, right? Like they just, because their olfactory nerve hasn't accustomed to the nerve yet, or to the stimulus yet, to the smell. But you've been sitting in here for a while and you don't even know that I am sitting here and I'm just wafting farts your way. You can't even tell, right? And so that's the difference between that, is that we would think that just like our sense of smell, that our brain should get used to that nociception and should then start to say like, oh, wait a second, this isn't a threat. This isn't danger. This is just information, right? And then we can make some decisions based on that, but it's not a threat to me. And it will do that with smell, noticing like, oh, I've smelled this one time and now I can just get used to it, right? And not perceive it anymore. But in pain, it kind of goes the opposite direction a little bit, which is a little counterintuitive. And so a huge part of what we do in chronic pain rehab is to try to start to rewire that slowly, to try to gradually get the brain used to that stimulus again and not perceive it as a threat.
Yes.
Right. And so, have you boiled a frog ever? You ever boiled a frog?
Have I boiled a frog? Living in the South, I feel like that's something I should have done, but no, not yet.
It feels like a rite of passage, right?
Okay, yeah.
I haven't either, but I've been told that if you are going to boil a frog, you should put a frog in lukewarm water first and then slowly turn the temperature up. Because if you put it in hot water, it's going to jump out.
Oh, right.
Because if you just drop it in a pot of hot water, it's just going to go bloop.
I really hope PETA isn't listening to this.
Yeah, we're not sponsored.
Not sponsored.
No animals were harmed in the making of this podcast. But in chronic pain rehab, we almost have to do that same thing. We have to, if we put you into a situation of hot water, of course it's going to hurt. But if we gradually turn up that temperature, then the brain can get readjusted to it again, and it can finally start to recognize like, oh, this isn't quite so bad, right? And so, that's a huge framework for how chronic pain is so different from acute pain in that sense.
Yeah, no, I think that's a really good thing to leave this with. It's just knowing the framework that I love the pirate one, the ARG. There's a lot of different frameworks that you could look up, but just when you understand, what process you're about to go through and can lean into that and accept that it's not going to be perfect, but there is a plan in place. Like that's just a really good thing for that psychological, the social part. That's one thing we touched a lot on in the first episode, the biopsychosocial approach, and having this sort of framework is really, really good. I found for the mental, the psychological kind of attacking of this sort of injury, of a chronic pain.
Yeah, that's awesome. Well, JT, I think we're going to wrap on that and take a little bit of a break and see you on the next episode. But this has been really good. Thanks for deep diving into that with me. There's a lot more discussion that we can have on this. So I'm sure we will do a pain part 3 at some point. But I think for now, the big highlights to circle back on, right, is understanding the difference between acute and chronic pain, understanding that in an acute flare-up, we're going to go through those inflammation cycles, the first 72 hours, the first 3 weeks before we're really kind of building momentum. And that in chronic pain, we don't really have that same kind of approach. It's more finding your entry point, trying to regain some control over the situation, and then re-expose the brain and the body back up to being able to tolerate those things and eventually have that expectation violation that we want everybody to have, right? And so I think those are good ways to separate those two things in our mind. And I really enjoyed hearing your perspective on some of that as well. So thanks for sharing.
I learned a lot from you, man. That was a great episode. Thanks for having it.
All right. We'll talk to you later.
Cool.